Hi, everyone. We're just going to give everyone a minute to come in from the waiting room. Good evening, everyone. While we're waiting, just another 30 seconds or so for everyone to come in from the waiting room, I just wanted to announce that we'll be having a Cornell Horse Symposium in person on campus in Ithaca on Friday, June 12th in 2026. And a lot of the topics will be kind of similar to what we cover in the seminar, but there will also be a lot more hands-on topics. And one of the reasons I bring it up before we have much programming is that Dr. Jager, our speaker for tonight, was one of the speakers at this year in 2025, our inaugural Cornell Horse Symposium, where he presented some cases, and it was so popular that we brought him back, dragged him back for a seminar as well. So that'll be Friday, June 12th in 2026. And we haven't decided on the programming yet, but we're always happy to hear feedback or any interest areas people have. So feel free to reach out. We'll send out a survey as well as a follow-up to this talk. Okay, so it looks like everyone from the waiting room has gotten in. And now I'd like to introduce our speaker for tonight. So Dr. Mason Jager is with us tonight. He is a veterinary pathologist and a generally cool person. So he's, in addition to being a veterinarian, he was in my class at Cornell, which was cool. So a longtime friend. He also has a PhD and is boarded in anatomic pathology, and he'll explain a little bit what that means. And then he'll also give us a quick overview of kind of his background in horses, some of his research interests, and then I think of special interest to the audience, like what do pathologists do? What kind of stuff do they find? And then some cool cases to go over. So thank you very much, Dr. Jager. Looking forward to it.
Thank you, Dr. Goodell. Hi, everybody. Good evening. Thank you for that very nice introduction. And so we can just jump right into it, as I say. Okay, great. So a little bit about me, just so you have some frame of reference. I'm originally from Connecticut, where I was born and raised. I come from a horse family. My grandmother was a DC of our local pony club. She had run for probably about 40 years. And so from an early age, I was an equestrian. And so here you have a little picture of me in some of those earlier years. And I stayed in pony club up through high school. Here I am at one of the national championships for quadrille and dressage, which was just a ton of fun. And so, I've always had a passion for equine medicine. I would say that I'm not necessarily specialized in equine pathology, but I'll talk about in a second kind of where I fit into the overall program. I did my bachelor's from University of Connecticut. I did my DVM, PhD, and board certification in pathology at Cornell, my residency at Cornell. In between there, after my DVM, I did do 3 years of general practice in small animal medicine in Connecticut, which at the time was basically one of the few jobs available in Connecticut, even though I trained to do mixed practice, including equine and ambulatory. Today, I'm an assistant professor at the College of Veterinary Medicine, and my tissue specialty is liver across all species, and my research is on viral pathogenesis in horses and a couple of other species. So this is just a plug for some of where my equine research fits in. As I mentioned, I'm not an equine specialist per se, but I do study equine viral hepatitis and liver disease. I'm very fortunate to work with a number of really fantastic colleagues across multiple disciplines. And so we've put out a number of papers looking at equine parvovirus, equine hepacivirus, and some other projects. And we've got some other papers in the pipeline. For any of you who are curious, this little horse in the upper right is jaundiced, which is a common manifestation of liver disease in horses and other species. So chances are high that most people have not interacted with an anatomic pathologist. It's a specialty that's kind of behind the scenes. So I thought I'd just take a second to explain a little bit about what anatomic pathology is and what it is that we do. So it is a specialty within veterinary medicine, much like internal medicine or surgery. Um, like some of the other specialties, it's 4 years of undergraduate training, 4 years of veterinary school, and then a 3-year residency followed by board certification. Uh, we're anatomic pathologists basically diagnose disease in animals. They're also commonly academic, so they teach future scientists and veterinarians. They help conserve wildlife and the environment through diagnostics, surveillance, epidemiology. We, like many field practitioners, are also kind of an important line in detecting emerging and transboundary animal diseases. And we also conduct research to understand the mechanism of disease for the advancement of animal and human health. One way that I kind of put it is that we recognize patterns in tissue to diagnose disease. We're basically just computers with eyes, and we look for patterns to try to figure out what's going on. As I mentioned, pathologists can work in academia. That's where probably about half of the anatomic pathologists work. We also work in diagnostic laboratories and pharmaceutical companies. How do they do these jobs, or what tools do they use? As you'll see kind of in this presentation, there's basically two areas. One is postmortem examinations, also known as a necropsy, which is essentially an autopsy, same thing that you might see a coroner do on TV or on CSI. We also use histopathology, which is where we look at tissues under a microscope, again, to look at patterns to see what might be happening. Not everything is doom and gloom and death for anatomic pathology. About half of the caseload we see here at Cornell are biopsies. And so these are samples taken from live animals where we diagnose things, anything from inflammation to genetic diseases and sometimes cancers, but it's not always fatal, which is good. We also use other techniques like electron microscopy, fluorescent microscopy, other kinds of advanced things to look at tissues. So something we get asked often, or that we encounter a lot, is, why do we perform postmortem examinations? And hopefully, maybe by the end of this seminar, you'll see some examples where doing the postmortem examination was able to kind of illuminate kind of our understanding of what's going on. As I mentioned, the main thing is to identify the cause of disease or death in a case. A lot of times, this is to provide closure for owners and their veterinarians. If you've been dealing with a disease for a long period of time and it's been a frustrating experience where you and your veterinarian don't necessarily understand what's happening or why these things are doing the things that they're doing, pathologists can sometimes be helpful, at the end to come up with a diagnosis. And so that provides educational value, not only for, again, the veterinarian, the owner, the staff at the veterinary hospital. They're usually included in this process. And then here in academia, veterinary students. Of course, I should include also pathologists in that, because each case is a learning opportunity for us as well. And an important, sometimes overlooked component of it is we can sometimes identify causes of disease that might affect other animals. And so this could be an infectious disease or a toxin. I have a case later on that is of a parasite that, a horse owner would want to know is an issue in their herd if they have multiple horses on a property. And so we can sometimes provide that information to help other animals. In this world, we also have an occasional case that's submitted for insurance claims. And so some insurance policies require a full postmortem examination to be performed in order to have some kind of remuneration. And then research, I'm a nerd, I can't help it. We're always looking to try to better understand what's happening and why. And so we perform research not only prospectively, so we work with researchers here at the college who are these large studies going on, but we can also look retrospectively, which means we look back through our records and see if we can identify patterns. And so, it's no additional animals are lost. And so we can learn tremendous amounts of information. Cornell has archives going back about 70 years. And so we can look through those cases and see if we can identify interesting trends. So just kind of show you the workflow of what happens. So you'll have a veterinarian or a pathologist performing the postmortem exam. I say veterinarian or pathologist, both are veterinarians, but this can include your regular general practitioner. And so they can perform that exam either on the farm themselves and collect pictures and tissues and then send them to a diagnostic lab, or they can send the whole horse to the diagnostic lab for an examination here. We then save tissues and fixative, like formalin, so that we can process them down the road. Sometimes we'll also freeze tissues in case we need to do any ancillary diagnostics like a bacterial culture or virus testing. Once that tissue is fixed and a little bit firm, then we section it. And then we take those sections and put them and embed them in paraffin, which is basically wax. And that allows us to make even thinner sections that then get put on a glass slide. And that allows us to look under the microscope with, numbers of different stains. And so that's what we have here at that last step. Okay, so that's the nitty gritty of kind of what we do and a little background. I'm happy to answer questions at the end too if anybody has any questions about pathology in general. So I have a couple of brief case studies, and this is just a warning, that this presentation includes graphic images of lesions from dead horses that some viewers may find disturbing. Viewer discretion is advised. There will be, blood, so it's a bit of a trigger warning there. These are all from our educational archives, and so this is just actually a great example of one of those side benefits of pathology is that we are able to take these pictures and share them with audiences like you or our veterinary students or other clinicians to further their education. So with that, I'm just going to dive right in with our first case. Oh, by the way, these pictures are not of the animals in these cases, just representative. So first up, we have a 28-year-old gelding who had mild colic at home that was unresponsive to Banamine treatment in the field. On presentation to the hospital here, the horse was quiet, mildly dehydrated, but otherwise stable. They did note the veterinarian did note during their exam that it was difficult to perform a rectal examination. And unfortunately, the horse's clinical signs got worse despite aggressive in-hospital medical management. And because of the poor prognosis and the worsening of clinical signs, they decided to pursue euthanasia out of quality of life concerns for this horse. So this is a picture of a horse post-mortem, obviously, I suppose. Just to kind of orient everybody, we have what would be the head is to our right, the tail would be to our left. Here we have the thorax or the chest, where we have the lungs and the heart. And here we have kind of a tangle of intestines in the abdomen. Now, things, post-mortem kind of bacterial overgrowth can happen really quickly, and we can have a lot of gas production in those intestines. And so they might not normally look like this while the horse is alive, but this, within about half an hour or so, we start seeing some of this gas distension of intestines. We can see the cecum coming down here along the side of the body wall, but this kind of knot of small intestines and colon are abnormal even for a horse post-mortem. And so that's something that kind of caught our eye when we first opened this abdomen, that there might be something going on with these intestines. On closer examination, we noticed that there was this round, soft mass associated with this tangle of intestine. So just to orient everybody again, we have loops of intestine here. And again, you shouldn't have this tight kind of accordioned ball of intestines. And at first, it wasn't 100% clear what this mass was, but uncovering it, we realized that it was actually a mass of fat. And so this is adipose tissue, and it was attached to a stalk that it connected to where the source of the blood vessels come from in the abdomen. And so this is called a strangulating pedunculated lipoma of the small colon. In this case, it's the small colon. It can strangle essentially various parts of the intestine. And then as a result, we had gas distension. And because the horse was uncomfortable, we did have cecal displacements. These are things that we make note of as we're doing these exams. Strangulating lipomas are something we see fairly commonly on the necropsy floor. It's more common in older horses. The thought is that you have these little fatty tumors, they're benign, that grow on the mesentery, which is the fatty tissue and blood vessels that hold the intestines. And over time, they kind of, because of that dependent weight from the mass, it kind of gets longer and longer and longer. And it becomes this kind of medieval device almost where because of gravity and the movement of intestines, you can have the intestines looped around that pedunculated stalk. And so this can be obviously very painful for the horse. And sometimes these things are slowly progressive, which was likely the case in this horse. It may not have been strangulating in the beginning, but as the horse moved around and you had that gradual compression of the intestine, it became more uncomfortable. And so this is just one common cause of colic that we see in horses. So our next case is a 1-month-old thoroughbred colt. This foal had a history of fever, diarrhea, and a wound over the joint. Like most foals, he was a little bit overzealous and I think encountered a fence in the paddock. Unfortunately, despite, again, aggressive hospitalization with aggressive antibiotic therapy, the foal unfortunately did have a poor response to treatment and so was euthanized. And there was a lingering question as to why this horse was so sick despite antibiotics. And so they wanted to have a better understanding of what was going on. So this is another image again. So the head would be to our right, the tail would be to our left in this image. These are the lungs. Now, overall, these lungs, while they look kind of dark, a little bit purplish, overall, they look okay. We don't see any obvious masses. We don't see any hemorrhage. We have our heart down here, our liver over here. You can see some of these intestines peeking out, our diaphragm. The ribs have obviously been cut, so we can have this view. And the image on our right here is actually a close-up of lung tissue. And so there's a little ruler here. These are centimeters to give you kind of an idea that we're talking about something that's about this big. And what you cannot see, but you'd have to take my word for it, is that if you felt these lungs, you could feel these little nodules, anything ranging up to a golf ball probably. And so when you sectioned into them, you could see, this is more normal lung parenchyma around it, kind of spongy. And then at the center, you have this white to tan, well-demarcated, firm tissue. And that lets us know that that's something abnormal. Lung should normally be spongy throughout. And so now we take that from our necropsy floor, we preserve it, we section it, and we look at it under the microscope. And so this is what would happen for most of our cases where we want to have a better idea of what's going on microscopically. So since I realize not everybody looks at lung histology on a daily basis, I have some controls here. So on our left is normal lung tissue. And, as you might expect, it's going to be mostly air, right? This is where we do our air exchange. This is how we breathe. And so it looks very sponge-like. You should see lots of clear space. There's very few cells and blood vessels filling in the space of a lung. And on our right, we have lung tissue from this foal. And really none of it is normal, but there are grades of abnormal here. And so in this left section here, the highlighted in orange, you can still see a little bit of that clear space here and there. And so this lung was still getting some air. This would be a pretty moderate pneumonia. But the area on the right, circled in red, you see very little of that clear space. And if we look closely, and on the left, we have our normal lung tissue. These are alveoli, the space that normally holds air, and they should be clear. On the right, we have lung tissue from this foal, where it is wall-to-wall inflammatory cells. You don't see any of that clear space. And most of these are neutrophils, and they are loaded with bacteria. And you'll have to take my word for it, because it's hard to see a little bit in some of these images, but these are little cocci bacteria. And that is a clue that we can use to identify what pathogen might be involved. Now, of course, being 2025, almost 2026, we can use other techniques like culture or molecular diagnostics to confirm the diagnosis. But being a little bit old school, I still like to be able to make these diagnoses based on microscopy. We also saw lesions in other tissues that went along with that wound. So even though the wound itself was responding well to care, when we looked at cross sections of bone, and so this is an example of a cross section of bone. This is a condyle right here. This is the joint. So if you think of your shoulder, for example, it's one of these ball and socket joints, and that's what we have here. We've taken the saw and cut it in half, and so we're looking at it kind of in the middle of the bone. And this is what normal bone should look like. It looks spongy, but it's actually quite hard, and it should be this tan to pink color. But when you look over here, the area highlighted in the red circle, we have this well-demarcated area that's a little bit tan, a little bit paler than some of these areas, and it's got this red rim. And that's our clue that there's something going on here. And so that lets us know that there's osteomyelitis, which is a bone infection. And in this case, the same bacteria from the lungs spread through the blood into the bones. And so that's one of the reasons that this foal was so sick. And this bacteria, in this case, was Rhodococcus equi. And this is a fairly common cause of bacterial pneumonia in foals. Usually they're 1 to 5 months old. What's a little bit scary about this is that it's actually in the dust or the soil of most farms. It's shed in the feces of other foals. And so it gets in the soil, it's ubiquitous. There's no point in trying to get rid of it. It's probably everywhere in the environment. But what ends up happening is that during dry, dusty seasons, that dust can get kicked up, the foal will breathe it in, and depending on how many bacteria are in that dust, they may develop a pneumonia. Sometimes it's subclinical, which means that they're infected, but they don't have any clinical signs, and then they can recover on their own. Sometimes it can actually spread to their intestines, and it can cause diarrhea. Again, most of those foals tend to recover, and they do fine just after that. But every once in a while, it can progress to pretty severe pneumonia with fever and lethargy, which is kind of feeling really down and out. And what can be tricky is that treatment often requires a long course of antibiotics, and diagnosis before death can be a little bit challenging. But a lot of practitioners know to look for this, and this would be high on their radar for a foal with pneumonia, bacterial pneumonia, if it falls in that age range. So just a reminder about this disease. And then our third case, also a thoroughbred. This is an older horse, this is a 4-year-old thoroughbred who presented for lameness at the 3/16 mark during training at a racetrack. Radiographs performed on the track almost immediately confirmed a pastern fracture. And because of the poor prognosis, the horse was euthanized. Again, this picture is not this horse. Yeah, obviously for privacy concerns, we don't like to show pictures of our actual horses here. So this is some pictures that we took during our examination. So these are the limbs removed to allow kind of a more thorough examination. Once the skin is removed, you can see this dark red gelatinous tissue just above the hoof. And this is an area of hemorrhage. So maybe some of you have seen this before, on your farm and your own horses, not without the skin, hopefully. But these areas, these limbs can bleed quite a lot. And so we were curious as to what was going on, see if we can confirm what the radiographs were showing. And just to kind of give you an idea of where we're looking in some of these images, I have this red square here. We are looking at this joint end on. And so you have the cannon bone essentially here at the top, and then the hoof would be more towards the bottom. And the bottom right here is what you would normally expect this condyle to look like. It should be a single piece of bone spanning this joint. But instead, what we have is a comminuted fracture. Comminuted meaning that you have all of these fragments. And it almost looks like a kind of a pile of rocks. And so this is a very severe, catastrophic fracture of that proximal phalanx bone, mostly because of the just sheer amount of weight on that bone. And as I'm going to comment in a second, one of the advantages of doing a postmortem examination in this case is that there are changes that radiographs or x-rays can't really pick up. And so definitely the clinicians knew about that fracture based on the x-rays, but they weren't necessarily going to be able to know what is going on in the other joints or in the other leg if there were subtle changes. And so part of our examination is to look at the other limb. So the fractures in the left leg, we also look at the right leg to see if there's any patterns that we can recognize there. And so these are the sesamoid bones from the other leg. And if you look, you can see normally a joint surface should be nice, smooth, and shiny, kind of like over in this corner over here. But in the middle here, you see it almost looks like cat scratches down the articular surface, which is the joint surface. And that's abnormal. And that's a sign of abnormal wear. And this is something that can be a precursor down the road to fractures of this bone. So these are the sesamoid bones, kind of like a knuckle bone on a horse right down here. And actually, that was the navicular, I think it was pointing out in that picture. But the one of the little knuckle bones here, the sesamoid bones, they are a common source of fractures in our racehorses. And so I thought I'd point this out. We were talking about research before and how these necropsies can be beneficial to horses in different ways, not just horse owners and veterinarians. So a number of years ago, the New York State Gaming Commission started a partnership with Cornell University where we perform postmortem examinations on all horses from NYRA racetracks that die or are euthanized. All of them get their postmortem examinations, whether they die on the track or in the barn or off season. It doesn't matter. They all have an examination. And that program started in 2012 and is still going on today. And the findings from this study, which has taken many, many years now, has already shown some improvement in reducing fatalities. So this study came out in 2017. I believe Dr. Palmer, who kind of runs this for the New York State Gaming Commission, is probably working on the next generation of these reports. But between 2012 and 2015, they dropped the fatality rate by about half. So there's a dramatic improvement. They're able to take the information from these exams and say, okay, these lesions are associated with fractures or near fractures. What, can we take that back to the practitioners? Can we take it back to the trainers and have them incorporate it into their planning? Because they look at the training schedule, they look at the weather, they look at the racetrack substrate, they look at everything combined with the necropsies to try to come up with recommendations. And so that's been a really, I think, positive net benefit for the racing industry and just the horse management in general. And these are just some pictures kind of some of these other lesions. And so kind of like that foal I showed you before, sometimes when you cut bone on section, you're able to see subtle changes that may not be obvious on an x-ray. And so we have more normal bone here on the right. This surface here is the joint surface. And just like that foal, you can see this kind of pale tan area that's demarcated by red. And that's an area of sclerosis, which is a thickening of the bone, and also some hemorrhage. And that just lets us know that this bone is diseased. And so we can go back and compare that with the leg that may have had a fracture and say, hey, this lesion may predispose a horse to a fracture. Is there a better way we can diagnose this before they get to the racetrack? And then this is an example of the sesamoid bone fractures that I was talking about. And if you look really closely, you can see those score lines again, those little cat scratch-like fracture indentations in the bone. And this is an example of what can happen with chronic repetitive injury. Those bones will actually just fracture and fall apart. Okay, I also just have some selections of kind of random diseases that we sometimes see on the necropsy floor. I will say that some of these are maybe a little bit less common. Of course, most field practitioners can diagnose the common diseases themselves, and so we may not get the most common diseases here on the necropsy floor, but I thought I'd share just some cool cases that we've seen over the last couple of years. So this is something called fibrinous pericarditis. So just like some of our other views, we have our lung tissue over here. This is the heart, believe it or not. We have our ribs down here, and the heart, unlike some of our previous images, which should normally be like a nice smooth surface, has this kind of shag carpet looking appearance. And all of this is something called fibrin. So this is something that comes out of your blood vessels with inflammation and kind of polymerizes into this kind of stringy material. And this heart is completely covered in this material. And so as you can imagine, it makes it really difficult to conduct and contract and keep the blood flowing. And so sometimes this is something that a practitioner might recognize on ultrasound, but it can still be kind of difficult because being the deep-chested animals that they are and with lungs in the way, this can still be kind of a challenging thing to diagnose before death. This case, I don't think we cultured an organism. This was idiopathic, I believe, meaning we didn't come up with a diagnosis. So similar to that, this is a case of pleuropneumonia. So pleura being the lining of the lungs and the chest. Um, this is the rib cage that's been kind of reflected forward. We have our lungs. Things are a little bit flipped here in this image. The head is to the left, the tail is to the right. And all of this kind of neon yellow material, this is fibrin, just like what was covering the heart. And some of you may know this disease by its kind of more common name of shipping fever. And so this is the disease that can, some horses can be predisposed to. They call it shipping fever because, well, I don't know that they've worked out the pathogenesis exactly, but one thought is that because horses, their heads are usually tied in the trailer, they may not be able to have as much motion, and some of the bacteria and dust may settle in the lungs. And so that plus the stress of shipping may predispose them to pneumonia. Streptococcus equi zoepidemicus is the most common bacteria that we culture from these cases, and it can be really dramatic. As you can imagine, it's going to be really difficult to breathe when you've got all of this material between your lungs and your chest wall, which is normally very slippery. And so that's just an example of that. This is another example. This is a little bit more inflamed. So the head is to our right, the tail is to our left. This is the diaphragm here, and some lungs, and then the chest wall is over here. And again, you have this really stringy, friable material that's coating everything, and that's the fibrin. So here's an example of gastric ulcers. So this is a common issue in high performance horses. Cause is not always understood, but if you're giving Gastrogard or some other kind of gastroprotectant, it's to try and reduce or manage these. And so just to kind of orient you a little bit here, so the stomach in the horse is broken into two areas. One you have is kind of a more protected, we call squamous portion. And so it's got layers of dense cells that kind of protect it from mechanical abrasion from like grass and everything. And then we have kind of a more mucosal, more like our stomach, where this is where you have acid production that's going to break down some of that feed. And the normal stomach in this portion should look like this. It should be kind of white to tan and kind of rough looking. All of these areas that are well demarcated, they're depressed, they're red or pink. These are all ulcers. And so as you can imagine, this is going to be really uncomfortable. And so you may not understand it, why your horse is being particularly cantankerous. Maybe it's just the weather, maybe something else is going on, but you can imagine if there's acid sloshing around in their stomach, this is going to be really irritating. And so this is a common cause, I think, of some behavioral abnormalities. And there's ulcers down here in the mucosal portion as well, which is a little bit unusual. We tend to see it more along this junction between the two zones. This is one of my favorites because this is a very unique horse lesion. This is something called hemomelasma ileae, which is quite the mouthful. But this is a section of intestine, and you have these raised, well-demarcated dark purple changes. And these are really just accumulations of blood. And nobody really knows how these develop. The thought is that it might be parasite migration. But actually, all these years, we've known about it for hundreds of years, and nobody still has a really definitive explanation for it. But it's something that we see really commonly. And again, it's very unique horse change. This is another example of a strangulating lipoma, so kind of a little bit different. So instead of having that knot or tangle of intestines, here it's almost like a balloon animal where that lipoma, which is right here, that fatty tumor has just kind of wrapped around and incarcerated or entrapped that piece of intestine. And so you can see it's really gas distended. And these are some vessels that are really congested or dilated. And so that's, again, kind of a common cause of colic in some of our older horses. So this is a granulosa cell tumor. Believe it or not, this is an ovary of a horse. And normally an ovary should be, if the horse is not ovulating, it should be a fairly homogeneous or kind of consistent tissue throughout, almost like what's over here in the far corner. It is not supposed to be cystic like this. And so what ends up happening is that these neoplastic cells try to mimic a follicle more or less. And they're still producing tons of hormone. And so you can see this in mares who are exhibiting stallion-like behavior. And so there's actually like a clinical manifestation. They act more aggressive. They might be mounting things. This is a pretty common diagnosis. Thankfully, this is an example of something that can be diagnosed in the field. Horse can have surgery and then have it submitted as a biopsy, not a necropsy. And so we can give that information back to the clinician and the horse owner. And luckily, surgery is typically curative. But that's just kind of a cool thing. And on ultrasound, clinicians will look at this and it has a really classic honeycomb-like appearance, as you can imagine. This is an ethmoid hematoma. So this is a cross-section of a skull of a horse. So you have your brain up here in the upper left. These are some of the sinuses. This is the mouth down here at the bottom right. And this is all nasal cavity and the nasopharynx. And then this is something called a guttural pouch. And what's abnormal here is this accumulation of dark red material right at the back of the nasal cavity. And this is a hematoma. And so this is just blood that has accumulated in that spot. It can happen for a number of reasons. Sometimes it can happen from nasogastric intubation. So if you've had a horse who's had colic, obviously they have to pass that tube through the nasal cavity. If it bumps up against the bone there, it's very fragile, very blood vessel heavy. They can have lots of nasal hemorrhage, and then they can develop these hematomas. Sometimes they can develop for other causes as well, but this is something that we see every once in a while on the necropsy floor. This is just another example, a little bit larger, filling up a more extensive part of the nasal cavity in this horse. So this is an example of laryngeal hemiplegia. So if you've ever had a performance horse or a racehorse, because it's typically the ones who are exercising, you might hear what are called roarers. So they have a stridorous breathing. And that's because their larynx, instead of being nice and open on both sides, one side kind of collapses a little bit. And so there's a lot more turbulence there. And this is what that looks like. And so we're looking at it from the top. This is the larynx of a horse that's been removed. And so the tube, the airway, is kind of just beneath where we're looking here. And this is skeletal muscle. And what's great about this condition is that we have a built-in control. So the left side is affected, the right side is unaffected. And so normally you should have quite a bit of skeletal muscle here. That's this red-brown tissue with these little striations. But on the left, we have a lot more white tissue, a lot more of those white streaks. And that's just atrophied muscle and fibrosis. And that's because the nerve that innervates that muscle has atrophied. And so the muscle itself has atrophied. And so this is how we can confirm this diagnosis on postmortem. Obviously, you can do other less invasive techniques to identify it clinically. But this is what it looks like once the larynx has been removed. I mentioned before the guttural pouch. This was something that I did not really appreciate until vet school. I will admit, it's not, I think I probably talked about it in Pony Club at one point. But it's another kind of unique horse structure where it's this potential space that's in their skull and it's air filled. And, normally it's empty. But they can develop infections in that space. And it's really difficult to control infections because the blood vessels are not kind of as involved there. And so this is just an example. This is what it might look like on a horse you have in the field. It kind of looks like strangles, which is normally a lymph node that's affected, but you'll have this swelling just behind the mandible. And then if you look inside the skull, you'll have, depending on the type of infection, you'll have all of this pus or other debris in that space. And what's really dangerous there is that there's some major blood vessels that pass through that space along the side, and that bacteria and infection can actually erode that space, and you can have quite a lot of hemorrhage there that can be fatal in some cases. Everybody's favorite, bots. Maybe you've seen the bot eggs on your horse's legs. So the flies will come, the lady's eggs, the horse will kind of groom that area, and the eggs, which is totally gross, the eggs will kind of sense that heat, emerge, and then jump into the mouth of the horse, and then they begin their long journey through the body. And there's two different kinds of gastrophilus, which is what this organism is, but at least one of the species ends up in the stomach, and this is what they look like. These are little larvae. They just kind of nibble and bite into the stomach wall. And embed there until they complete their life cycle, and then are passed in the feces and then emerge as the as the flies. So pretty gross, but if you've ever wondered what they look like on the inside, that's what they look like. Another common condition that hopefully you've never had to encounter yourself is laminitis. And so I have here a normal picture in the upper left corner and abnormal in the bottom right. So this is a cross section of the hoof, kind of like what we were looking at before. And so we've got our navicular bone here, our second phalanx and third phalanx. And normally the lamina are like these fingertip like extensions off of basically the bone. It's kind of a skin like appendage on the hoof. And they form these interdigitations with the keratin of the hoof that kind of go like this. And so it creates this really super strong bond, which is how this massive animal can stand essentially on the little tippy toes and on the fingernails of their tippy toes. So you've got the really strong interdigitation for any number of reasons, whether that be just inflammation, systemic inflammation from colic, or steroids, or endocrine disorders, lameness issues. Sometimes that interdigitation starts breaking down and things start coming apart. And this is what we see happening. So again, you have your hoof wall up here. This is the sole. This little triangular piece is bone. And this piece of bone should be parallel with the hoof wall, but here you're seeing it drop down. And this is something that a clinician can see on x-rays, but this is what it looks like in real life. And in really severe cases, the tip of this bone will actually push through the sole. And that's obviously open to infection and then other issues. It's exceptionally painful condition. And, sometimes we're lucky in nursing them back, but it can be really challenging. This was just another example. And so you can even see a little bit of this dark red, this hemorrhage here. And again, it's getting really close to pushing through that sole. And so this is one that we commonly diagnose. This is one that we see every once in a while in hospitalized cases. And so horses, one of the beautiful things about veterinary medicine is just all the differences between species. Horses, as it turns out, are very sensitive to high and long doses of non-steroidal anti-inflammatory treatments. So think of like aspirin, essentially, for horses. And if they're dehydrated and sick for other reasons, they can have kidney injury. And so this is a kidney from a horse. And most of this tissue is normal, except for this little triangular area here. And this area, so normally blood would start out here in the periphery and kind of work its way down into this space here where it becomes urine. And right at the end here, we have necrosis. And so it's well demarcated. It's this yellow color. And this area is predisposed to injury because of changes in blood flow from those non-steroidal anti-inflammatory drugs. And so this horse might have blood work values that suggest kidney disease. And so that's something that we see every once in a while. Anybody who has an older horse, and has the dentist come by or your veterinarian do teeth floating, this is just an example of dental attrition. So some of our older horses, they no longer erupt. They'll start having uneven tooth wear, where this tooth is no longer erupting, and then this tooth has nowhere else to go, and so it starts coming down. You start getting wave mouth, hooks, points, that kind of thing that can affect oral discomfort. They can also get food impactions here, dental abscesses, those kinds of things. And so just a gentle reminder, don't forget to have your dentals performed fairly routinely in our older horses. This is a case that was, or I should say, is an example of providing feedback or information not only to the owner who might be looking for closure or just has questions as to what happened with their horse, but also the clinicians. And so this was a horse that was exhibiting signs of colic. And I knew that the horse was uncomfortable. But when the clinician would do the rectal exam, they didn't feel anything in that area. They were able to feel some gas distension and thickening kind of further up the intestines, but they really weren't sure what was going on. And so it was submitted for necropsy to try and figure out what was going on. This is the colon, the small colon. And within, so already in this picture, it should be nice and smooth. You can see a little bit of deformation of that wall. It looks like something jagged might be in there. And we open the intestines and we certainly see fecal material here. But then if you were able to touch this in real life, you'd be able to feel this and you'd notice that it's very hard. And this is what we pulled out. And this is called an enterolith or a fecal lith, depending on where it is in the intestines. And this is a little crazy, but you can have, it's almost like a gobstopper where you have layers and layers and layers of mineral that build up on, let's say, like a piece of grass that's passing through the intestines. If you have a high calcium diet, sometimes this predisposes it. But they form these basically rocks in the intestine. And if you cut into this, you'd see layers of grass and other things in it. But this was very sharp and causing a lot of discomfort for this horse. So we were able to provide, again, some information for that client and the veterinarian. So this is an example of suppurative meningitis. So suppurative just means pus, and this is the brain that's been removed. So this would be towards the nose. This would be towards the spinal cord where it'd be coming back. This is the cerebellum. And if I point your attention over here, you'll see that there's kind of this milky white-like tissue in the brain. And so that's the pus that's associated with this bacterial infection. It's just in case you ever wondered what the horse brain looked like. It's about the size of kind of two fists put together on horses. This is a little bit abstract and hard to appreciate, but this is a ventricular septal defect, a heart defect that we identified in a racehorse, believe it or not. It was 4 years old, racing just fine, I suppose, until it passed away from other injuries. But I can tell you, I don't have a good normal control picture here other than up here on the far right, but I can tell you that this hole is not supposed to be here. And this can have significant effects because basically blood flows from one side to the other instead of passing through the lungs normally. And so that can result in exercise intolerance. So these horses just don't perform as well. So perhaps this was earlier in this horse's career. I mentioned before, how some of this information can go back to the herd level. This is an example of an intestine from a horse, and we have this area, again, kind of this well-demarcated, depressed area. And I can just tell you, so this is called an infarct. So this is dead tissue within the wall of the intestines. We don't see that all the time. And when we looked more into it, we discovered the culprit. This is back to histology. This is in a blood vessel in the wall of that intestine, and we found a parasite. And so this is the large strongyle, which is one of the main reasons that we have regular deworming protocols for our horses. These parasites are ingested, they move through the intestines into the blood vessels, clog up those blood vessels, and then cause necrosis of the tissue downstream of it. And so we don't see that as much these days, but we're starting to see an increase in those cases because some of these parasites are becoming drug resistant. So this is one of the reasons that we do regular fecals. We recommend regular fecal examinations to see what you have going on in your herd of horses. So that was kind of cool to see something that we don't see as much these days. Again, this is just this round thing is the parasite inside the blood vessel. This is a fracture in the skull. And so sometimes, I say horses are always creating new and interesting ways to hurt themselves. And we see this quite often. And this horse, my own horse did this once. It was very scary. Was getting onto a horse trailer and decided to rear and then reared too far, fell back and hit their head on the ground. And unbeknownst to the owner at the time, there's a nosebleed. Horse started acting abnormally after that. There was a fracture. This was a little hard to see, but we have a fracture right here. So this should be one continuous bone. There's a gap right here. And then there's blood or hemorrhage in multiple tissues here. There's also another fracture right here. And so this blood comes up and then compresses the brainstem, the cerebellum, and other tissues, and you start having neurologic deficits. Cyathostomiasis, this is the small strongyle. So this is also a piece of intestine. And here you can see all of these small encysted parasites. And this isn't always a problem unless you have massive migration. All of these larvae will emerge all at once, and then you can get a pretty sick horse. They'll have diarrhea and other issues, and that's what it would look like clinically. This is the section of lung, equine multinodular pulmonary fibrosis. This is something that's gained kind of a lot of attention in the last 20 years or so. This is a virally induced change. And so you have more normal lung tissue over here. Again, if you were touching this, it'd be nice and spongy. This whole area that's tan, I can tell you it's very firm. And under the microscope, you'd see lots of fibrosis, lots of inflammatory cells, and this now we know is caused by a virus, a herpes virus. This is kind of an unusual one. I don't have a lot of tumors in this presentation, but this is hemangiosarcoma. So this is a tumor of blood vessels. This is a tumor that is more common in dogs and horses. But this is what normal-ish lungs look like for a horse. They be kind of pink and soft. But you can see these dark red lesions throughout the lungs, and that's a metastatic tumor. So the tumor has spread to the lungs, and it's just forming these little abnormal blood vessels. I think we're coming up to the end here. This is cervical stenotic myelopathy. Again, quite the mouthful. But this can be a condition in young horses where their vertebral canal is just a little bit too small. And either it can be small all the time or small only when they move their head. And so you'll get compression of the spinal cord. And so this is the spinal cord passing through here. These are your vertebra. And as you can see, it's relatively open over here and over here. But right here, you're starting to get compression of that spinal cord. And so some of these horses will be called wobblers because they're really uncoordinated in how they move. And you can imagine that compression of the spinal cord like that might cause that. Excellent. So that's it for me in terms of pictures. I'll stop sharing right now and then see if there's any questions anybody has. I'm happy to answer anything. I also have my email on here if there's anybody that wanted to have any kind of follow-ups.
Awesome. Thank you so much, Dr. Jager. And anyone, there are a couple questions already, but if you have a question, feel free to type it into the Q&A and I can ask him here. If it's a longer question, we don't get to it, you can always reach out to us at the seminar series email, or he has generously shared his own email. So one question is to do with case 3. I don't know if you need to go back to it necessarily. It was about the sesamoid fractures. And I think the main crux of the question is, do we know what causes that kind of injury? Is it to do with like takeoff in the gaits? Is it because they're running at a young age? Do we know much about the cause?
Well, I will say that I'm not, my area of specialty is not musculoskeletal pathology. So there are some pathologists who study just these injuries related to racetrack injuries. I don't think that we know. I think it's a combination of things. And so I think it's secondary to other arthritis and other issues going on in that joint. You might have little fractures of bone coming off or from that joint, and then gets into the area there and kind of causes those score lines. But this is part of why they're doing these studies. And so I don't think we've come out with those results just yet. But they're getting more advanced. So, and New York is not the only state that's doing this. California has a really fantastic program. Kentucky obviously has a very similar program. And there's actually now a national registry trying to get to the bottom of this. And I think the hope is that we'll be able to start parsing out what's going on. Most of these changes are chronic, so they're happening over months to years. And so we can't really say which activity is causing the problems. I think most of the catastrophic fractures where it's finally reached the last straw, that happens most of the time during training or on the track during a race when it's really the heavy forces and the horse is really moving forward.
Yes. So I think in summary, another question that asked a somewhat similar question, there are a lot of factors that go into these types of injuries. It's not, like he's saying, it's often a lot of cumulative things, and a lot of people really interested in that. And I think, so usually after the seminar, we send out a follow-up with the recording, and we can share a couple resources on that too, if people are interested. And then, there's also a question, let's say someone did submit their horse for necropsy at Cornell. What kind of a timeline are they usually looking at? Because there are stages, I think, right?
Yeah, that's a great question. And so if a horse owner is interested in submitting it, so first thing, they have to submit through their veterinarian. So that's probably why most horse owners have not heard of a pathologist, because we tend to work directly with the veterinarian. And so they would reach out through their veterinarian. The horse would come here for the necropsy. We will often have what we call a preliminary gross report within the first 24 hours or so. And so that'll be a document that the veterinarian will get that will have our initial impression based on this necropsy. And then we collect our tissues, we process them, and it takes between 7 and 14 days to get those slides back. We look at them and interpret them. And so most people have a final report within 14 days of having a horse submitted, but
Wow.
they'll have some idea ahead of time if
Hmm.
we can interpret based on the postmortem.
Hmm. Yeah, and I think the beginning of your talk went over nicely that there are like those two pieces, big pieces where we're looking at it grossly, and then we're also getting a bunch of images later on, give more details sometimes. Speaking of detail, someone has an interesting question about neutrophils. You said sometimes you see neutrophils filled with bacteria, and they're wondering, is this because the cells are getting rid of dead tissue, or are the cells being attacked?
That's a great question. And so, in this case in particular, we're talking about Rhodococcus equi. We see the bacteria in the neutrophils. We also see them in macrophages, which are kind of the more traditional cleanup cell. And so, part of it's because they're cleaning up debris, they're capturing some of those bacteria. But Rhodococcus is kind of interesting because it actually prefers to live inside the cell. And so they have ways of living in a cell that would otherwise be trying to kill them, which is why they have to be treated for so long with antibiotics and why it can be so difficult to treat. So Rhodococcus is a particularly troublesome bacteria,
Very sneaky, yes.
very sneaky.
And emphasizes the importance of looking at cellular level.
Yeah.
Um, so interesting question here. I don't know if you'll have the answer, but they're asking if there's any kind of parallel work being done in the standardbred industry for racing horses.
Yes, so we do get submissions from standardbred racing, but they are not subsidized like the
Right.
thoroughbred racing industry. And so we do have still racetracks and trainers who are interested in trying to find out answers. It's kind of a different program. That's what we do see them as well. Yeah.
Right. Okay. So
And
it's
steeplechasing
definitely open to
and
submissions. Yeah.
oh, absolutely. Yeah.
Yeah. Yeah. Yeah. Yeah.
And again, that's not my area of expertise, but I do think we see sometimes different injuries
Hmm.
uh, with the different types of racing
Right. Yeah, that makes sense.
and
Um,
breeds.
right. Yeah. Yeah. Lots of patterns to find, right? Um, Another question, you kind of alluded to this in a couple of the cases, but your talk, of course, was focusing on necropsy, but your example of, like, for example, the granulosa cell tumor, there are a lot of cases where you don't have to, you can send samples, for example. Could you touch on that a little?
Yeah. And so
Yeah.
you mean just like in biopsies in general, do you think?
Yeah, like,
Or
so you don't need to send a whole horse every time to get answers.
oh yeah, no,
Yeah.
that's why I was saying that's the good thing. It'd be kind
Mhm.
of depressing, I think, if we just dealt with postmortem examinations.
Hmm.
Um,
Hmm.
where we can inform people, but we may not be able to make a clinical difference in some cases.
Hmm.
Biopsies are about half of what we see. And so, let's say your horse has an eyelid mass. The clinician can do some surgery, remove that mass. The horse is fine afterwards. They can
Hmm.
submit it, and we can let them know, is this a tumor? Or is it just something right before a tumor? Is this something that we think is going to spread? And so, yeah, we see quite a lot of that. And yeah, that's also an avenue. And so again, the clinician, if you have a biopsy taken, it's probably going to be looked at by a pathologist.
Right. And I think maybe some people don't realize when they say we're sending it off, it means it
Yeah,
goes to you, basically, right?
that's right.
Yeah. So thank you very much. You've also gotten a handful of thank yous and hellos.
Oh, thank you. And
I
hello.
think, yeah, and excellent summaries. And I think we're just about out of time there. If you didn't have time to type a question or something occurs to you later and you were in this talk, feel free to email us at the seminar series email or Dr. Jager directly. And we'll also be sending out that survey for the Cornell Horse Symposium. So if you want to see more topics like this, or if you have some other ideas for stuff you'd like to see hands-on in June 12th, 2026, then let us know. And otherwise, everyone have a good evening and thank you very much, Dr. Jager.
Thanks so much for having me. Thank you, everybody, for joining us.
Good evening, everyone.